Hello, good evening, everybody. I hope everyone has had a lovely Tuesday. And we are tonight going to be talking to a wonderful medical expert about medically induced menopause. So hopefully Dr. Sonia is coming in now, which is great. Hey, Sonia, thanks for joining us.
Thanks for having me.
Great that we got on okay. I'm coming to you from our beautiful Ngunnawal country here in Canberra, and I just want to acknowledge the traditional custodians here in Canberra, the Ngunnawal people, and also pay my respects to elders past, present and emerging. And Sonia, you're in Melbourne there, and I actually don't know who the traditional custodians are there.
Well, there's a few of them. There's the Koori Nation, there's the Wurundjeri tribe, and there's others, and I'm ashamed to say the names don't come to my tongue.
Wonderful.
I acknowledge you. Hello.
Hello. Many of you will know that tonight we're going to be talking about medically induced menopause, and I guess this kind of started a little while ago when we think about the people who are in our community, in the Inherited Cancers Australia community, and also think about the people that are in the Jean Hales kind of community. So we have lots of people who are entering medically induced menopause either because they've had a cancer and a cancer treatment, or they have removed their ovaries for risk reduction. And obviously you guys have lots of people in your community that you support outside of the cancer space. So really looking forward to kind of diving into it tonight with you, Sonia. But I'm just going to read a little bit of a bio about you and say a very big welcome and thank you for coming on tonight. So Dr. Sonia Davison has lots of letters after her name, which means that you've got a bunch more qualifications than I do, but is an endocrinologist with a special interest in women's health and has worked in this field for over 20 years. She's a chief fellow at Jean Hales for Women's Health and has worked at the Women's Health Research Program at Monash Uni. She has a private practice. She works at Jean Hales as well, and she's done her PhD and postdoctoral research looking at hormones in women, including the measurement of lots of fancy hormones and their relationship with age, mood, sexual function, and cognition. So lots of the stuff we'll be talking about tonight, hopefully. Sonia is a past president of the Australasian Menopause Society and is a current board member of the Asia Pacific Menopause Federation. So obviously published widely, lots of research, lots of scientific meetings, podcasts, webinars, and was also recently on the TV show The Truth About Menopause with Miff Warhurst. We are very lucky to have you here tonight. Thank you. Thank you. Thank you.
Thank you for having me. And hello to everyone. I hope I can help one woman, but if I can help many women, I'll be a very happy person.
Yeah. So, Sonia, this kind of came about because we in our Inherited Cancers Australia community were kind of, for years had looked at what people are talking about in our online support groups. And, there's always lots of people mentioning medically induced menopause. There's confusion, there's conflicting information. People, I guess, sort of see a huge gap in information. So what we did with you guys, it was late last year, we kind of partnered together and thought, here's a big gap. Let's see what we can do to kind of reduce that gap and empower people with information. So kind of push forward, how many months? 8 months, and we've held focus groups. We've got feedback from 800 people in the community. We've had, you guys have created these evidence-based resources. So I guess with that in mind, I'd love you to tell us a little bit about you and what kind of drew you to women's health and I guess the menopause and hormone space in particular.
Well, I just got lucky. Sometimes in life you plan things and other times you just sort of fall into it. I was doing my endocrinology training, so that's hormone specialty training after doing my physician's exam, and that's after being a doctor after 6 or 8 years. And I was very lucky to land a training position at Jean Hales, and that really opened my eyes to the whole world of menopause. Jean Hales really started with menopause expertise and then really exploded out and branched out into women's health in general, but it's got at its core heart, it has a menopause focus. So I just loved working with menopause. I finished my training at Gene House. I was very lucky to do an amazing PhD with Professor Susan Davis there. And I have my blinkers are on, and I'm just focused on midlife health for women, and good health for women from teenage years to their 90s.
Oh, that's awesome. What a, yeah, that's a great thing to do. Just you accidentally kind of landed in it and just loved it and kept going. That's awesome.
It was a good fall.
Yeah, absolutely. It's like a good fit for you. Um, so let's start with the basics. There's, natural menopause, and then there's medically induced menopause. Can you talk us about how it's different and maybe explain, the difference between a treatment-induced menopause and a surgical-induced menopause?
So we're all designed genetically to undergo menopause, which is just the last period and sadly the last egg. It's from the Greek.
Mm.
We will all undergo it if we get to the right age, between 45 and 55. A premature or early menopause, premature is before 40, early is before 45 years. So if we live and we're healthy and well enough, we will undergo menopause. The median age in Australia is 51, 52. If, however, both ovaries are removed for whatever purpose, it might be cancer risk reduction, it might be because of endometriosis, it might be because of terrible big cysts or something else. There are lots of reasons that we might need to remove ovaries, and we never do it without trepidation and without a good conversation, I hope, these days. They used to just take them out. Years ago, they removed them. That was it. Very, very often a form of hysterectomy. So we call that a surgical menopause. And the moment a woman's ovaries are removed, that is a surgical menopause. But some women will undergo menopause for other reasons, and that's because of chemotherapy, radiotherapy, or other treatment. Some people might just get very unlucky. For example, if they've had a nasty viral infection, that might knock out their ovaries as well. So a medical induced menopause is where actively trying to reduce that menopausal state because we're trying to avoid cancer risk, or we're trying to treat cancer, or we're trying to treat another disease process like endometriosis. But there are lots of different reasons that women might go into a medical induced menopause. And sometimes we actually might like to put women in a menopausal state, for example, if they have terrible PMS, DD, and they be psychotic or suicidal, just to see the relief from those hormonal fluctuations and higher hormones, if it actually is their life worth living, and then might add back some treatment but that's a very specialized. Some of these cases are very special, as you know.
Yeah, that's right. That's right. We did talk a little bit about how some menopauses can be temporary and some can be kind of permanent. And can you just lead on a bit from what we were talking about then and tell us when that might be temporary, when it might be permanent?
So if both ovaries are removed, that is permanent. And if a woman has undergone menopause, typical age 45 to 55, that's usually permanent.
Mm.
Some women are quite unwell when they undergo cancer treatment, and they might have the chemotherapy or radiotherapy, and they might stop having periods. And then it gets very confusing because a lot of those women are told that they're menopause, but then when their cancer is treated and maybe a year or so down the track, they might be quite well. And because is recovering and effectively well, sometimes the ovaries, which were sort of just trembling, they might start up production of eggs and production, because the eggs make hormones. So sometimes that is a temporary menopause because of cancer treatment. It might also be due to treatment we give to actually rest the ovaries, and that can be a temporary thing, because some cancers we just want to rest the ovaries, hoping that after the treatment we can remove that treatment that did the ovaries out for a bit, and hopefully restore fertility for some women. It really depends on the circumstance.
I have heard, or I have seen in our groups, some women that are a bit frustrated because they've got to go through menopause twice.
It's like
It's not laughable.
after menopause. That's also another thing that you never thought of, really.
Yeah, yeah. So, from your clinical experience, what kind of challenges do people face when it is like a medically induced menopause?
I think it's a really tough thing because often these women are landed with, oh, there's an inherited cancer gene. And the next thing is, oh, I now have to act on that. And oh, now I'm going to have menopause at a much younger age. And I think the hardest thing is they're choosing it themselves. They might be advised, but the one who actually signs the consent form on the surgery or goes to the surgeon and says, I need to have this done is them. And these women typically feel well. So it's pretty hard when you're reproductive age to go out and do something really courageous and say, please take my ovaries out. And they don't know what's happening after it. So I think that that's a very big consideration because they might feel well and then I've got the surgery, that's one thing, and that's scary. And then there's the consequences after that. So I think, and we weren't very good at managing this before. We were good at sort of nailing cancers and treating those, but even after cancer treatment, we were never very good at treating menopause. So the inherited type of cancers and that risk reduction management, that's really just blossomed in the last 10, 15 years.
Yeah. Can I tell you, it's funny, I was actually having a conversation with some ladies in a support group today. Literally one of them said, just feels so funny making a decision to remove part of my body that is perfectly fine right now, I think. So yeah, there is exactly as you say, that question about, wow, I feel fit and healthy now, but I have to kind of do this to reduce my risk in the future. And, you know, from a certain age onwards, that's what the guidelines kind of recommend. So
and you've got to remember that these women are, you know, typically they're with children, they've got elderly or aging parents, they're working, they're trying to have a relationship. I know not everyone is in that situation, but that's a really tough gig. And these women, extreme courage is what I've always been blown away by because I don't think I would have that courage. I'm a chicken.
yeah, it's a tough choice, I think. Now, tell me, obviously you work in this space, you have plenty of, people that you're working with clinically, day in, day out. Why is it really important to have information and resources specifically for medically induced menopause?
I think it's one of the areas that we just haven't, we sort of missed.
Mm.
And it's really tricky because when women have sourced information, it's for natural menopause, typically 45 to 55 age. So the messages have been quite different. And it wasn't purposeful. It's just because this is an emerging area and we needed someone enthusiastic like you and your team to make us realize that, oh, this really needed to be done. So it absolutely wasn't purposeful. I'm glad that this has been done because this has been one of the holes in menopause management. I'll say that.
Yeah, it was obviously Sarah and your Sarah and our Sarah that had the discussion about, this big gaping hole in resources and information for people in our community and certainly in the cancer community. So we're so pleased when you guys are like, yes, let's do this together. Yeah, it's great. And so what do you think? Like, obviously, we're a patient-focused organisation. We don't have any medical experts per se in our team kind of at the moment. But why do you think it's really important to have medical experts like yourselves who are reviewing and, developing these resources?
Well, I started in this area in 2001. You might not have been born then, Robyn.
Oh, please.
Some people in my home weren't born at that age. So I think the issue there is that, again, there are lots of people out there giving advice, and those people might be making money out of menopause or selling a product or whatever. We've seen a lot of so-called menopause influence at the moment, and unfortunately, they don't always give the right messages. They don't realise that, for example, medically induced menopause is a very sensitive area where you need a lot more care and consideration and some careful thought. And really, to guide women through this, you do need, some years under your belt, and you do need enthusiasm, you need knowledge, and you need to know what the science and the research studies have shown. it's no good just reading an article and just coming up and you can't manage it properly.
Yeah, I must admit, this was very much a collaborative process with you guys, working on some aspects of it and us kind of leading other aspects of it. And I really, when I first received the information, the documents from you, I was blown away by the amount of evidence. Here's the link to the reference. The reference is here. There's another link. Here's another aspect of it. And I was really just like, wow, these are great. And yeah, pretty excited to be able to put all that information up on, well, both of our websites, right?
I'll tell you that everything on the Jean House website is so scrutinized. The team have got me scrounging around from all sorts of articles and resources to just make sure that the absolute evidence is portrayed there, so that we do not want to mislead women at all.
And what do you think from the other angle? You're the medical experts. How do you feel about having our consumer aspects, us kind of telling you, well, this is what we want. We're consumers.
We need it. We absolutely need it. It used to be used to go to the doctor, in the 60s or whatever, and sit there timidly, and they used to tell you what to do, and used to walk out thinking my questions haven't been answered. We've emerged from that, and I think after the pandemic we've got very good about talking about health as well. So we're now a lot better at listening to what's missing and listening to experiences, and hopefully working with those and getting the information out there. I always give talks to GPs, and I say, if there's something, and the community, if there's something on the Jean House website that you think isn't covered, please let us know. We will be really busting our chops to try and get something out there that's some good information.
And what do you think, with these resources, how do you think they're going to help people be more prepared kind of through this experience?
Well, they're extremely considered. When I was reading through it, wow, this is amazing. Everyone's thought of every single thing. I was trying to fault them and add bits, but I hardly added anything. I didn't, it was so well considered. I think it takes it beautifully through. This is happening to you. This is the situation. This is what you expect. These are the questions you need to ask, and this is what you might expect afterward. So I think it is a beautiful addition, and thanks to you, your team. Really, I think we're the first ones driving this, and thanks to those at Jean House who pushed the barrow along.
Yeah, thank you. We obviously did get a lot of information from focus groups and from our survey, and I was actually personally quite surprised at how many people just went, I didn't know, what is a menopause specialist? What are these clinics? What are you talking about? I didn't know I could get what's an endocrinologist? So is there a place where people can go where they can find lists of support services or clinicians they can go to for support?
I always think Jean House for Women's Health is an excellent website to start with some good advice for consumers and some good webinars for health professionals as well. But the Australasian Menopause Society absolutely focuses on menopause, and we have 30 information pages that are very useful in this area. But the main thing for women out there to know is we have a Find a Doctor webpage. So this is listed by state, locality, postcode, etc. It lists, they're mostly GPs, and they're mostly really great women's health GPs. Of course, we can't say that everyone is perfect on those pages, but that's a very good start. And most of those GPs on that list would say, well, this might be slightly out of my expertise, but they would have some good core information on menopause, and then would be able to refer off. It is very hard for these women to get advice. There are the public hospital menopause clinics. There are some menopause after cancer clinics. There are some genetic counsellors who will refer off when they know that someone has a BRCA 1 or 2 gene issue. So there are various pathways to do this. And just, I know in the community, there's a big Facebook menopause group as well, and I know some of those women are very dedicated and they get answers, so they know what to ask. and they know where to seek. So that might be something for your community also to look into too.
Yeah, great. Well, that's very good to know. And what about like regionally and rurally? I'm guessing there's still the providers potentially either on that list or, some that are online or via telehealth.
There are some telehealth services. Again, at the Australasian Menopause Society Find a Doctor webpage.
Yeah.
I'm also Endocrine Society of Australia, ESA. That's the endocrinologist sort of database there. That will list doctors by specialty as well. So if you're a senior GP and think that you need to take it a further step, because some GPs just won't have this knowledge about this special situation, so that might need referral. Or gynecologists, there are some gynecologists who have a specific interest in this area too.
Mm. I must admit, as someone with the gene mutation myself and someone that's removed her fallopian tubes and ovaries to reduce my risk of ovarian cancer, when I was having my surgery, I had a healthcare professional just say to me, just stay on the pill for the rest of your life and you'll be fine. And I was thinking, well, I'm on the pill now and I'm removing my ovary. At the time, I only had one, and I was thinking, I just don't feel like there's enough hormones going on there. Like, that's interesting advice. And took me probably a little while, about 6 months, that I thought, do you know what? I think I'm going to go and see someone that specializes in this and maybe just have another chat.
It again takes courage to hear one message and say, I need a new message. So I've heard that story a lot. Just keep trying to get the answer. It's about treating bothersome symptoms, quality of life, and so making sure that your bone health, heart health, and brain health are all right and catered for if you're making a decision to the ovaries earlier.
Yeah, absolutely. Someone's asked a question. They were just saying they were living in the UK and they heard about some non-hormonal drugs to help with hot flushes. And I'm guessing maybe this person's had a hormone-positive cancer diagnosis. And do you know, is there anything like that available here?
So there are two things that don't involve any medications. There's a beautiful cognitive behavioural therapy book for menopause by Myra Hunter, a UK expert. It's got a beautiful cover and it's about $30. I'm not promoting it, but it is very useful. Hypnotherapy can be very useful for treating flushes, mood, and sleep. So you might not have known that. But there are a number of medications. So there are two groups of antidepressants. One called the SSRIs, things like Arapax, sertraline, paroxetine, etc. We don't really know how they work, but they increase the serotonin in the body and they seem to reduce flushes and sweats, and they can be useful for mood as well. There's also venlafaxine, which is called an SNRI. Gabapentin's an epilepsy agent, believe it or not, that's good for sleep, flushes, and also pain, funnily enough. And there's a very new treatment called Veoza or fezolinetant, which is specifically for hot flushes and sweats. There are no hormones in any of those medications.
Excellent. Well, that's a very comprehensive answer to that question.
Beautiful information sheet at the Australasian Menopause Society and some really amazing information about non-hormonal treatments as well at the Jean Hales Women's Health website.
Yeah. Great. I want to know, obviously medically induced menopause affects people differently. Everyone is different, and I mean natural menopause also affects people differently. What would be your one best bit of advice to give to someone who's kind of looking down the barrel of a medically induced menopause?
I think it would be very useful to do a symptom score. So if you look on the Jean Hales website or on the Australasian Menopause Society website, there's a symptom score and it lists typical symptoms. So I would do one of those before the treatment and then I would do one after the treatment. That's really the only way that you can correspond how you felt before and how you're doing afterwards. And then if you do make an intervention and make it add a treatment, it'd be worth doing that again. So I think that's very worth doing. I think it's worth knowing who your supports are and leaning heavily on them and telling them I'm going through a bit of a thing here, please help me. And of course, you need a really good GP. If they don't have women's health expertise, you need their support too.
Yeah, great. I want to invite people to ask some questions if they would like to ask any questions on here and you haven't already kind of chimed in.
Well, I'm going to you, Robyn. I think, and this is very personal, but I think you've experienced medical menopause yourself. Can you tell us about that and how it changed your understanding of what support is needed?
Yeah, I guess, like I said, I probably, when I went into it, just kind of looked at the person who was managing me and doing my surgery and just went, oh, okay, I'll listen to you, and kind of, oh, you know, I even went into surgery, and probably the week before the surgery, my surgeon had said, oh, we might put a particular hormone implant in. It was a pellet, and he said, this will release over a year and you'll have to have that once a year, I think he said. And I was thinking to myself, oh, I'm quite active, and I probably didn't like the idea of every year having a little stitch and a cut or whatever in my tummy. But I was so naive that I, even a week leading up, I didn't realize it would take a month to get the actual pellet, compounded. You can only get them done in certain places. So I was probably a little bit underinformed when I went in, definitely. And afterwards as well, I just kind of went, oh, okay, well, this is me. And obviously as well, and this is what our resources kind of talk a bit about, is you've got that option to keep your uterus or remove your uterus when you're making these decisions. And based on what you choose, that will have an impact on your hormones. And you can probably talk to that a little bit, Sonia, more than I can.
Well, I'm always a bit frustrated if someone's finished their family and don't need the uterus. I'm always frustrated that the surgeon will leave the uterus in, because if we are looking at hormone therapy, it's much easier just to give estrogen. When we have to give progesterone, often there are issues with bleeding if the uterus is still in. So I'm thinking if a woman is undergoing removal of the ovaries and the fallopian tubes, it's almost a kindness to remove the uterus as well if they aren't needing that uterus. I know some women do want to keep their uterus. So that's one aspect of it. So if the uterus is gone, you only need estrogen if you're allowed to have estrogen. And I know some women aren't allowed to, but if the uterus is there, it can get a bit messier with some form of estrogen and the progesterone. So there's lots of layers to this very already complex area.
Yeah, there is. And, sometimes on the flip side of that, people are like, and like me, I'm like, oh, do I need to take, I might leave my uterus because do I need to take a body part out if I don't really need to? Like, there's all, and that's the thing with this. There's so many gray areas, and there's so many, well, what do you value and what kind of suits your lifestyle and stuff. So, yeah, it's not just a simple.
I think if someone is going through this, to read the resources, think
Yeah.
of questions really carefully, and try and ask them. I know it's very hard in a busy specialist appointment. You've got 5 minutes to say hello and goodbye, and there's only 5 minutes in the middle sometimes. You feel a bit lost. Just maybe be a bit prepared, is the other thing. Do your research, know what questions you really want answered.
Yeah, that is great advice, and it definitely leads us to just talking about, there are two resources on both of our websites, same resources, just different branding and written probably just a little bit differently, that talk about questions to ask if you're about surgery and surgically induced menopause, and then questions to ask about treatment and treatment induced menopause. So those are quite big. They're very comprehensive lists. So if you want to go in, have a look at them, and think, oh, these are the 5 questions I'm going to ask because they're the ones that are important to me, then great. After considering all the other stuff, I think that's great, and that's a way to open up a dialogue with your healthcare team. And yeah, just to remind everyone who's kind of watching now that these are available on both of our websites, which is really exciting. Sorry, Sonia, I've just had another question. It's not a question, it's just a comment that someone had their uterus removed at the age of 30, and that contributed to bladder and bowel prolapse in her early 50s. So, yeah, there are risks and absolutely complications that can come from these, really sensitive kind of surgeries, right? And those are the things we want you to be discussing, hopefully using these resources.
Also, don't feel like you're drowning in information. It is a very overwhelming process. Just get your family by your side, your partner if you have a partner. Take it bit by bit. Some women I've seen visit the area, close it over, and then revisit later when they're able to when they're able to just do a little bit better with it. So just don't drown in it. Reapproach it. Have the courage and ask for help.
That's great advice. Great advice. Someone's asked if there are any specific recommendations for regular health checks after medically induced menopause for people in their 30s.
Well, there's a beautiful list on general women's health checks at the Jean Hales website if you hunt around. It's difficult because they're a younger age from 30, so I don't think there's a specific thing here. I always ask about exercise, weight, quality of life, sleep, flushes, vaginal dryness, urinary symptoms, just general menopause symptoms, but general health. And I might chuck in a few up things like checking the thyroid, iron stores, and those sort of things. And bones might be a consideration if you're not able to give estrogen in. So again, this is a specialty area. It was a good question. Have a hunt around and keep asking.
Someone else has asked if there was a preference or a recommendation in a gel or a patch for estrogen. Is one more effective than the other?
Well, it's a good question because menopause is literally hot at the moment. It's a very hot topic. There's a lot of interest worldwide, and we think that it's this interest worldwide is that a lot of women want to be on hormone therapy now, whereas before they did not want to. So it's very hard to get patches, for example. So we're using a lot more of the gels. One goes onto the arm. You just literally wipe it on the arm. One you rub into the thigh or the tummy. There's no one correct patch or gel or whatever. That patches, for example, it's applied to the tummy or butt, and some don't like that, recognition that there's something on me that means I've undergone treatment. So it all depends on the person. But they're an easy thing. You put them on Monday, take them off Thursday, put a new one on. But again, they're difficult to find. Some women love the patches. Some are great on the gels. Some are good on tablets. It's whatever suits the individual.
And to know if you're absorbing it correctly, would you, can you test bloods for that? How do you know that, or is it just symptom wise?
When a person comes into my room and says, I feel normal, we've got the dose right. So it's about control of all of those things: flushes, sweats, mood, sleep, aches and pains, vaginal dryness, urinary symptoms, ability to focus, ability to work, ability to maintain relationships. There, we don't do levels unless it's a specific concern.
Yeah, that's good. And I know, work and relationships definitely came up a lot in our focus groups. People were kind of, I don't say underprepared, but definitely surprised by the impacts that menopause had on relationships and I guess cognitive function and capacity at work. So, yeah, I guess ensuring that stuff's going okay, probably does mean that you're on the right information if you can take.
Partners might not understand this. They might be supportive, but it's going to be a really intuitive person to know what the person next to you is really undergoing and what's going through your head.
Well, it's 7:35, so I might wrap it up there and just say thank you very much, Dr. Sonia, for coming on. And there's one last little question. Is there any value in checking hormone levels prior to surgery to remove ovaries before natural menopause?
Not really, because estrogen levels are about 150 at the start of the period. They go up to 1500 at ovulation, they fall down again. The average is about 400. If you do one hormone level, it's going to be anywhere if you're still cycling and not on the pill, not pregnant, not breastfeeding. So it doesn't mean a lot and it won't add a lot. It's about symptoms, quality of life, ability to function.
Oh, that's really tricky, isn't it? Gosh, aren't we complex creatures?
Very.
Fabulous, I might add. Oh, wonderful. Well, thank you so much for spending half an hour with us tonight talking about these great new resources and this information that is on both of our websites, so Inherited Cancer Australia and then also Gene House of Women's Health. All those questions that you can ask your health professionals when you go in and talk to them. But yeah, thanks for coming on, Sonia.
So
And
much for having me. See you again.
thank
Bye.
you.
Take care. Bye.